Welcome everybody to the Hypertrophic Cardiomyopathy Association's Facebook page. And we have a launching today of a new Hypertrophic Cardiomyopathy Association Recognized Center of Excellence, and that is UT Southwestern. And in a little while, we will have Dr. Aslan Turer and Dr. Mark Link join us to talk about the program a little bit. But before we start, I wanted to take a moment to remind you what a Hypertrophic Cardiomyopathy Association Recognized Center of Excellence is. It is a comprehensive model of multidisciplinary healthcare directed to hypertrophic cardiomyopathy and all of the aspects of HCM. So you will have involved in the program people from non-invasive cardiology, invasive cardiology, electrophysiology, cardiac surgery, genetics, social work, and pediatric cardiology, and all of the options within that, and of course, cardiac surgery. These programs work in a collaborative method, and the Hypertrophic Cardiomyopathy Association reviews these programs in a very thorough manner. You can find all of the guidelines on what a Hypertrophic Cardiomyopathy Recognized Center of Excellence is on the HCMA website at 4hcm.org. So now that I've given you a little bit of an explanation of what a Center of Excellence is, I'd like to welcome Drs. Turer and Link to the program. Good morning, gentlemen.
Good morning.
Good morning.
So I want to start out with a little bit of history. How come UT Southwestern decided to pursue a hypertrophic cardiomyopathy program specifically? How did it come about? Dr. Turer, you want to take this one?
Yeah, sure. So, well, I got to Southwestern in 2009, and I was very interested in seeing patients with hypertrophic cardiomyopathy. I was kind of struck, despite being close to the AHA and the large population in Dallas, kind of that there was no one place where patients with hypertrophic cardiomyopathy could go. So it was kind of slow in building and kind of coalescing the clinic together. And you and I spoke, I think, several years ago when we were first trying to get a team together. And it wasn't up until the more recent couple of years where we got a very good myectomy surgeon, and Mark Link came, that I think we finally had really a core clinical team and could leverage that with all the other things that we do really well here at Southwestern, like genetics and exercise physiology, and kind of bring it together. So yeah, it's been several years in coming, and I think it was just the last couple of years where this all coalesced.
I remember I went back to my notes, and it was April 1st, 2014, the first time we spoke. And yeah. I remember I have my notes from the conversation, and I said, here are a couple things you're going to want to look at and build, and you did. And I think that process that we helped set you off on might have taught you a few things about what the best models were for an HCM center. What have you learned over the past couple of years about HCM care and what's really critical to patients?
Well, yeah, you had referred me to talk to Lever at Cleveland Clinic and Marty Marin. I reached out to them, and I kind of realized at the time, there might be interested clinicians or really good echo people or MRI readers here, but we kind of needed to have a core dedicated team, a lot of flexibility in clinic to see patients who might come from afar. And there just had to be more institutional support than just a few kind of interested clinicians. So that kind of took some time and kind of formulating, but that was kind of the main thing. Any program where there were just one or two people who were interested never really crystallized into a program, a multidisciplinary program. So that was kind of the main message that I got from the people that I spoke to at the other established centers.
That's fantastic. And then comes in Mark Link. So with full disclosure, I must say that I have literally entrusted Mark Link with the care of my daughter and my niece. So he's actually, when at Tufts, put in devices into family members of mine. So obviously, when Mark said, I'm going to leave Tufts and I'm going to go someplace else, I said, but I still need you in HCM. So Mark, you're in Texas now. Let's talk about that.
Yes, I've been in Texas now a year and a half. And actually, I was not looking to leave Tufts. I was actually quite happy there. And then Ben Levine, sent me an email and said, hey, we're looking for a director VP at UT Southwestern. Would you be interested? And so what's the first thing you do when you get that email is you send it to your wife thinking she's going to say you're out of your mind. And instead, my wife said, no, you should look. You should see what it's like down there and see what they have to offer. And so that began my trek down here. And in the first time down here, I met with Aslan to talk about HCM and what was going on with HCM in Dallas. And it just grew from there. And here I am down in Dallas.
So you got your cowboy boots already?
Got my cowboy boots, my hat. Threw away my winter coats.
Rub it in, why don't you? So, okay, I have to bust Mark. It's just something we do. So I want to know a little bit more about the rest of the team. You know, we have a very comprehensive team down there and some unique aspects to your team that might not appear in other programs. So why don't you tell us a little bit about the team? Aslan, why don't you start?
Mark and I sort of co-direct the clinic. Pietro Bayona is our surgeon, who is excellent. We've had really fantastic outcomes. He's a charming Italian man. He trained at Toronto General and at Mayo, so he brought sort of some background in this area, and he's really been key to our program. We have several imagers who are dedicated to HCM, but one in particular, Vlad Zaha, who actually has a MRI protocol looking at myocardial metabolism and hypertrophic cardiomyopathy. And kind of one of the key people who, maybe as you were alluding to and Mark had mentioned, who is kind of unique to our program, I think, is Ben Levine, who's world renowned as an exercise physiologist, and he's so great to have here because we get so many questions, particularly from young adults and teenagers and then the parents of those kids about exercise and limitations and things like that. So we have protocols with him, and we kind of bounce. I frequently call him on the phone, just, hey, what do you think about this case? And we'll put people on the treadmill and do things that, we really leverage that connection, and it's been incredible for our program.
I've known Ben for many years. He and I were on a task force together for the ACC, and we struck up a conversation, and who knew where that was going to end up taking us, because he did ask me early on, who would you suggest for an HCM program down in Dallas? And I might have thrown a couple names out at him, but hey, he's a fantastic asset to your program and an absolutely insightful researcher. So I'm hoping to get some really interesting data from him. So Mark, you're the EP guy in charge of HCM there now, and we've got a lot of interesting topics that we need to learn more about in HCM, like atrial fibrillation and why it's so difficult to manage in HCM, and the role of devices and which device and when device. So do you have the time and the resources to really dig into these questions now that you're at UT?
Absolutely. Part of the reason I was hired was to, bring a academic research program here in EP. And one of my big fields is HCM, and I'm very interested in the arrhythmias in HCM. And the arrhythmias in HCM include AFib, which is very annoying in most people, very symptomatic, but also can cause heart failure and stroke. So it's not just symptoms that it causes, it's the downstream effects that can be devastating. And then, of course, I've always been interested in sudden cardiac death in HCM. It's a very relevant issue, a very devastating issue. And, over the years, we've learned that medications don't prevent sudden death, that only the defibrillator does. But we've also learned that not every HCM patient needs an ICD. And it's picking the patients that would most likely benefit from the ICD. That's been a very relevant research topic for me for the last 20 years.
And now we have the new question of transvenous ICD versus SICD, what's more appropriate, and how do we make those patient selections? So we're looking to you to give us some guidance in that as we move forward in understanding these technologies. So
yeah.
go ahead.
That's a very important question, because there are pluses and minuses to transvenous and sub-Qs, and it's not like one device is better than another. It's which device is best for an individual patient, and which device is best for patients with HCM who are often very, very young relative to other individuals getting these devices. So they're going to be living with these devices for 50 years. Very different than a patient with coronary disease and a dilated cardiomyopathy who may get their device at age 70.
Yeah, I went through 5 of them myself, so it's a matter near and dear to my ex heart, we'll call it. Right. So talk about research at UT Southwestern. You guys do have some protocols underway right now. Want to tell us a little bit about some of that research going on?
Well, we are, like probably many of the other COEs, getting this myocardia study up and online, which will obviously have a obstructive and a non-obstructive portion, and so that's currently, we're going through all those documents and negotiations now. And with Ben, we have an exercise protocol looking at high intensity exercise for patients with hypertrophic cardiomyopathy, and we have some patients from the clinic that you've referred who have been interested in that protocol. It will add to the body of literature here, which is relating to safety of exercise, at least in some patients. Vlad has an imaging protocol for patients with hypertrophic cardiomyopathy to help us understand a little bit more about maybe some cardiac metabolic dysfunction, perhaps in patients with hypertrophic cardiomyopathy, because there may be some therapeutic interventions that can be done there. And so those are the things that we're doing right now. And then Live HCM, we're a center for that. And then down the road, I'm also become really interested in the last year. I've seen a lot of patients who have had issues with autonomic dysfunction and maybe some problems with their sympathetic nerve activity, and so they get a lot of orthostatic hypotension or dizziness when they're standing, and it's not all related to obstruction, and it's happened even after septal reduction. And there's a body of literature about autonomic dysfunction as a mechanism for blood pressure drops after activity, but it's not really well characterize exactly what is happening. So Ben and I had sort of floated some ideas at a lunch we had a couple of months ago, and that's kind of, once these other protocols have kind of settled down, that's something I'd like to dive into a little bit more. So
I think that's an excellent point. We've actually had a larger than some people might expect number of people come to us originally diagnosed with POTS and other autonomic dysfunctions, and comes down to the true diagnosis being HCM with these autonomic features and a lot of orthostatic intolerance. And what does that really mean? We don't know, but I assure you, if you open a protocol, I definitely can find people who would be interested and appropriate to study in that regard. So I'm hoping that you do continue down that line. Mark, what's going on in research in EP?
Yeah, so I want to focus on 2 studies that are currently ongoing. One is the Live HCM. We are Center for Live HCM on the steering committee for that. We've enrolled quite a few patients already down here. So we look to be continuing with the evaluation of those patients and actually writing up of the study. And the other study I want to focus on is the study with Ben Levine, and that's the more intensive exercise. We have some data out of the University of Michigan that a moderate exercise program is not harmful to patients with HCM, and I think that's great data, because we want our HCM patients not to be couch potatoes. We don't think that's the right thing. But we're not exactly sure if intensive exercise is good or bad. There's certainly evidence that intensive exercise in heart failure with preserved ejection fraction is beneficial. And that is a somewhat similar condition to HCM. But there's also concern because of the risk of sudden death in HCM that intensive exercise may not be good. So we're working on a project that's just here where we implant implantable loop recorders that will monitor patients for arrhythmias and then put them on a relatively intense program, more intense than the one at University of Michigan, to see if this is beneficial or harmful. And we're very excited about that study.
I am too, because we definitely need some answers. I can tell you I've got people with HCM who are triathletes and even run marathons in the past. After their diagnosis, they cut it down to 10Ks or half marathons, but they are exercising rather intently. And the answer is we don't know if that's a really good thing, a really dangerous thing, or potentially even a bad thing for the heart muscle itself. So to get that data will be really helpful to the quality of life of many people with HCM. So we encourage you to keep that going, and we look forward to helping you recruit patients into a study like that. So
I'd also like to, one other thing that we've talked about before is getting more data, getting more surveys with HCM, specifically on AFib and sub-Q ICDs. And I look forward to working with you and the HCMA Foundation that we can get more data on these two topics to see about the relative usefulness of the sub-Q ICD and then how to treat AFib in HCM, which is a very perplexing problem.
I definitely look forward to working with you on that, and I've hinted to it in the past couple of videos that we've done here, that the HCMA is building a new database system that patients will be able to share their data with us so that we can ask better questions of that data set. So stay tuned for more information on that. It's probably going to be launched beginning of the second quarter, and we'll be able to ask very specific questions, and you'll be able to share your experience as a patient. And then we'll be able to work with researchers like our team at UT Southwestern and others to analyze that data and see what it really means and what actionable items we might be able to take from it. So we look forward to that. I do want to talk a little bit more about your surgery program, because we definitely need a surgery program in the South, and you've got an interesting mix there, because your surgeon is trained by first Toronto and then Mayo, and then he took a trip up to Cleveland and learned new techniques there, which earned me a big thank you at the summit, because he learned a lot more and saw all the differences. So tell us about the numbers that you've done in surgery and how the outcomes are looking down there.
Well, speaking to the outcomes, they've really been, I'll speak for him, they've been fantastic. I have to say that having inherited some patients who had myectomies or sent patients for myectomy where they had been not fantastic, it was really a relief to have a surgeon who I can look the patient in the eye and say, you're going to feel a ton better and your gradient's got to go away. And so we've had fantastic outcomes. Our numbers have really increased. I think we did in the last year, I think we did 25 or 30 myectomies, which is still below where we want to be, but every year we kind of do a lot more. So our numbers are building and our outcomes are really good. So, I definitely encourage patients who need a myectomy to meet Pietro and maybe visit our hospital, which is, kind of clean, nice, state of the art, and also, have them, we have patients who have gone elsewhere and kind of give them the opportunity to discuss that with those options with the patients who have gone to Cleveland Clinic or to Mayo or to Tufts, and happy to facilitate referrals up there, because the most important thing is that the patient gets a good result and is happy with their care, and also that it's nice to have a local center too, because a lot of the patients are from local and they want to have their family nearby too. So it's been good for us to be able to offer that to patients more in the last couple of years since Pietro got here.
And I will second that. He's been great to work with. He's been great for patient care. and the outcomes really have been superb down here.
Now, Mark, you have a lot of experience from the surgical program up at Tufts, which the volume's a bit higher, but you were there during its buildup as well. So are you seeing some similarities? What are you seeing?
Yeah, there's always a learning phase. And I think the learning phase for most procedures is usually around 25 to 50. And that takes a few years when a program's just starting. That was true at Tufts, that was true at Cleveland, it was true at Mayo. And now we're beyond that. I mean, Pietro's done well beyond 25. And so he's beyond that learning phase, and he's just superb. He's a superb, surgeon, and he's actually got a very great personality to work with patients also.
I would agree, and he's going to be getting the invitation hopefully later today from the HCMA to join us at the Surgeons Roundtable, which will be the end of April, where we're hoping to put together all of the thought leaders in myectomy around a table at the same time to share best practices, techniques, and hopefully create a white paper on best practices that their colleagues can learn from, and that we can truly get the message out to the surgical community that high volume matters in hypertrophic cardiomyopathy. And we want to make sure that patients get to the right place for the right surgery at the right time. So I will pause here with my questions to you by telling the audience that we will accept questions about HCM. We can't give specific information about your clinical diagnosis, but if you'd like to submit general questions either about the program at UT Southwestern or about HCM in general, you can submit those now. We'll be going over those in just a moment, so you can start submitting those. Mark, I wanted to kind of take this from a slightly different perspective, because you have been in two different programs now, and you went from a Northeastern program to the Dallas program. But what is unique about UT Southwestern? Why there for you, and what should people know about the history and the quality of the program?
Yeah, UT Southwestern is quite a place. It was established by the Texas legislature 75 years ago now, this year, with the goal to create a med school in Dallas, which Dallas didn't have. And they wanted an academic powerhouse, and they built an academic powerhouse in the med school. 6 Nobel laureates have done their work here, which is pretty impressive for an institution that started 75 years ago. They have built the clinical program. They started their clinical program with Parkland Hospital, which most people know, that's where JFK got his care. And about 10 years ago, they said, we want to branch into a university hospital. And that's when they dedicated themselves to really clinical care at a university hospital. They bought a local hospital that was actually quite small, and I never actually saw it. But 2.5 years ago, they started building an incredible state-of-the-art tertiary/quaternary care hospital, which is gorgeous. I mean, the EP labs in that hospital are gorgeous. They have, wanted HCM to survive and thrive. And so we have the complete support of the Division of Cardiology, the Department of Medicine, the hospital. Everyone actually is incredibly supportive here. And I think that's been a big benefit to not only our program, but me personally, that they have the support here, both in personnel, in funds, and in the ability to do research. That really is a spectacular place.
So I get to visit all the programs, and I was impressed with the facility and the institutional support that they're giving you. And I think you've got a really great foundation for not only a good program today, but one that's going to have roots in the community and last for years and years, because we know that HCM care isn't just today. It's generational, and we want something that's going to be, something that we can build on and bring the fellows in and train them and keep some of them and build it up and improve the care in the community as we move forward. Aslan, you trained over at Duke, another HCM program, which hint, hint, nudge, nudge is up for review by the board next month. So you came out of a different type of a center to here. Are there some things that you see that are different, better, unique from one to the other?
Yeah. I definitely feel, and again, this is reflecting my training experience from, 10 years ago now. But, like Mark said, we have a lot of institutional support here. Whereas, at the time it was not as much there, and I'm sure, and I think Andrew's really turned that, the program has grown quite a bit over that period of time. But we, particularly as Mark got here and Pietro's volume started to go up, it really became a thing here. And so that was, everything really over the last 18 months has sort of crystallized in terms of the importance to the community and to the hospital's clinical growth. So I think everything is kind of aligned that way here in our program. Similar to Duke's program, we are here and there, we're kind of a regional thing, and I kind of like that about my clinic, to be honest. There's, obviously I look forward to the day when people come from, wherever, Vancouver to get surgery with Pietro, or, a sudden death consult from, from Miami to go see Mark. But I kind of like that our patients are local. I do feel like we're serving a region here, and Duke was like that too. People would come from various parts of North Carolina to come to that. But that, right now I do like that element, and so I'm kind of a little codependent, I guess, with my patients. So the ability to see them more frequently, particularly when they're having issues, works well for me in our clinic.
That's fantastic. Yes, to answer the question that was posted, you can submit your questions now. We're going to get to those in just a second. My wrap-up question before Q&A to both of our guests this morning is, what are your hopes for the future of hypertrophic cardiomyopathy, both in the diagnostic and the management phase, or possibly even eradication? What are your hopes? Aslan, we'll start with you.
Well, that's a great question. Obviously, I think we all wish we could snap our fingers and kind of get rid of this. But, short of that, I think kind of an intermediate goal or hope for me is, particularly since we've got more younger, sicker patients referred from the HCMA, the challenge has been in the clinic trying to treat the younger, non-obstructive patients. There's not a lot of treatment options, particularly if their cardiac output's not in the zone where we would necessarily transplant them, or it's kind of low, but maybe we're kind of thinking they're going to need transplant, but is 18 the right time, kind of thing. And I wish we had better therapies for them, to be very honest. A lot of them have angina and shortness of breath, and of course it's a minority, but those patients who have it are very limited, and our options are really limited right now too. So, hopefully with the upcoming, Maverick trial, we'll have some additional therapeutics, but that's one that's one big thing. One thing that comes up, and just from a research standpoint, I wish I could understand and tell patients a little bit better, is what exactly happened? How and when, and what was the trigger, if anything, for this happening? And such a black box of understanding how they were well just a year ago and now so limited. And I wish I understood that. I feel like if we could understand exactly what was happening at that time, we would have a better insight into how exactly we could potentially stop things from happening, or not, keep hypertrophy from being as significant of a problem as it is. I think there's just a latency in us diagnosing things, so it's hard to do research in at that time, in that critical time period. And I wish we understood that better.
You and me both. Mark, what are your hopes?
The pie in the sky dream is to prevent it from ever happening, from developing itself phenotypically. That's a pie in the sky, but I think ultimately that's really possible with all we're learning about genetics. It is a genetic disease. It's a heritable disease. And it's probably more than a monogenetic disease, and that's going to be the future, is promoter and inhibitor genes.
Let's define that a little bit more. When you say monogenic disease, for our listeners, what are you talking about there?
Monogenic means one gene, and that's all that counts. So if one gene is abnormal, that's all that makes a difference, and that's going to give you the disease. And I think that's a simplistic notion that is true for some diseases, but I think there's more and more evidence that there are other genes that are important, and some people who have that one bad gene will get the disease and other people won't. And I think that ultimately is fascinating and could potentially cure HCM if we knew how to turn on the inhibitor genes or turn off the promoter genes. I think that's incredibly exciting. That may happen in our lifetime, that really may, but that is pie in the sky, and that's not what we're dealing with today. What we're dealing with today is the symptoms and the morbidity associated with HCM. And for me, that's the arrhythmia issues, the AFib, which is more difficult to treat in HCM patients than it is in many other patients. It's more symptomatic. They don't respond as well to ablation. Antiarrhythmic drugs are a little bit more concerning in HCM populations. So I think AFib, understanding how to treat it better is important. And the other real big problem is risk stratification. Who is at risk for sudden cardiac death? And, it's imprecise for sure at this point. We, both the European and the US systems aren't terribly accurate in predicting who's going to have a sudden cardiac death. So better prediction tools for sudden cardiac death, and then which device they should get. Should they get a transvenous or a subcutaneous device? I think there's so many questions out there with arrhythmia management and HCM.
Well, I'm going to jump right to the questions there because you dovetailed nicely into a question from Mary. She's wondering what the criteria are for implanting an ICD. You want to go over this for us?
Sure. There are 5 big criteria that we use in the States, and then the Europeans have a different one too. But certainly, if you've had a sudden cardiac death, that's a major criteria for any disease. And then the 5 big criteria is massive septal hypertrophy, so 3 centimeters or greater, a personal history of syncope. That sounds like it's concerning, and syncope is fainting, so a sudden episode of fainting. Then if you've had a family history of sudden death that's due to HCM, then the history of fast rhythms that are short in the lower chamber, something we call non-sustained ventricular tachycardia. And then the final one in the American system is if you drop your blood pressure during exercise. The Europeans also look at the age, and the younger the age, the more at risk, and also left atrial size. But in actual fact, most patients will come out very similar on the European scale and on the American scale.
Can you discuss late gadolinium enhancement?
So late gadolinium enhancement is something that's been coming out over the last 10, 15 years, is found on an MRI scan, and it basically is scar. And more data is coming out that the percentage of scar increases the risk of having a arrhythmia. It's not in the current guidelines, but almost certainly will be in the future guidelines, that if you have greater than 15% scar on your MRI scan, that's concerning for a risk of arrhythmias.
So the next question you also touched on earlier was recently started on blood thinners. I understand why. I am curious if anticoagulation behaves differently in an HCM heart.
Yeah, so what we know about AFib and HCM is that it's a major risk factor for stroke. And so anyone with HCM that has AFib should be anticoagulated unless there's really a major problem with bleeding. Traditionally, we've used warfarin, and that has been, the holy grail of these drug companies to try to replace warfarin, because there's so many problems with warfarin, with monitoring it by blood tests, with dietary restrictions. And so over the last 20 years, there's now been 4 agents that have been approved by the FDA that are warfarin replacements. And by and large, in every study that they've been looked at, they're at least as good as warfarin, and probably better actually in the prevention of stroke. And they have less risk of bleeding in the brain. So there's no reason to think that there'd be any difference in HCM. In fact, HCM patients were included in these trials. And so I think that the risk, benefit in people with HCM and AFib far is the benefit of using an anticoagulant. And I'm a big fan of the new anticoagulants. I am a big fan.
Great. So you have a member of your fan club here, guys. Annie saying that it's her two favorite guys in Dallas. And she also has a question. I'm sure that the volume of patients have increased. How is the clinic handling the influx of new patients? Are you looking to add new physicians? Not for me, of course. I'm not changing. So, any growth?
Yeah, it's obviously a balance. We want to make sure that we can handle the increased growth, and we've certainly seen more referrals come through the HCMA. And there are physicians there. There are a couple of people potentially for hire in the upcoming year, and there are fellows who are interested in doing HCM work as well. And then we just have to balance sort of the volumes with, we want to make sure there's access to clinic, and as the growth comes, we're open to hire. There may be somebody who comes on who's very interested in HCM, and we'll just see how that goes. We also don't want to pull too many people in to take care of this population, because then we end up sort of diluting the expertise of what we've learned from just experience and the volume of patients. So it's a balance, and I'm not sure that we're there exactly yet, but in the next year or two, probably.
And I will second that UT as a whole is growing tremendously. I mean, we went from a 200-bed hospital to a 500-bed hospital, and now we're adding a 250-bed wing on that hospital that construction started last year. So it has some growing pains. I mean, it does, but it's growing tremendously, not only in HCM, but in all aspects. And that's where, again, having the support of the administration is crucial. And they support us. They want us to grow, and they're helping with that situation.
I just want to go back on that one issue for a second and say one of the major factors that we look for here at the HCMA when evaluating a center is institutional support. And it sounds like a kind of a throwaway line, but without institutional support, you don't get the people that you need to take care of the logistics behind the program, not the physicians necessarily, but the admins and the scheduling and the technicians and all of the other people that are required to hold up the physicians at the top of the program need to be supported by the institution. And that's where the sustainability of the program comes into play. And that's one of the factors that we evaluate. Does it really look like the institution is going to back this up? Or are they just going to say, yes, send us some patients and we'll image them and we'll be happy and that's all we want? And, early in the HCMA Recognized Center of Excellence program, we found a couple of programs that really didn't have institutional support. And frankly, they don't last. They fall apart. So it is a very critical factor that there is that institutional support. We have a question from Kelsey now about pregnancy in HCM. I will stop and say that we have convened a writing committee on pregnancy and HCM for maternal fetal medicine. So there'll be some more data coming out in the next year on that one. But this is a great question. She's non-obstructive. She's had 2 pregnancies, but ended up with fluid overload or maybe a little touch of congestive heart failure post-pregnancy. Are you guys prepared to deal with these pregnant women and help them get through the pregnancy successfully?
I'll take this one. So, if you read the guidelines in the textbook, patients with hypertrophic cardiomyopathy should do very well with pregnancy. And that, when I first started, that's kind of what I took as gospel. And just like Kelsey is saying, I have been I've become very leery of, been very watchful of patients who are pregnant with hypertrophic cardiomyopathy, and not as much anecdotally the obstructive patients who I think the extra volume kind of helps, but the non-obstructive patients, we've had a couple that we've had to watch very, very carefully. And the last 2, I mean, everyone obviously survived the pregnancy, and the babies did fine, but it was rough on everyone involved, including myself. And it was a fluid retention, pulmonary edema afterwards, where we just didn't necessarily, I've become very watchful on the non-obstructive patient with hypertrophic cardiomyopathy. I think they have the potential to get very ill, and then that's a little bit more in distinction to the obstructive patients, where the extra volume is kind of helpful. You have to be careful around the time of delivery, particularly if there's blood loss and fluid. That fluid shift can be. We have to be careful of that. But the fluid retention, particularly in the third trimester leading up to pregnancy, and then a couple of days after delivery have been dicey. So that's not that makes me more paranoid than I was before. Thank you, Kelsey, for that. So
I'm going to add to the paranoia and share a personal experience. I did great through my pregnancy with my daughter, who is now 22, almost 23. But the delivery was challenging. They gave me an epidural. I crashed on the table. The last numbers I heard were 70/30. Oh, crap. I think they said some other words, but we're on video here. But it was the post-delivery time. I ended up with pneumonia and pleurisy within 90 days of my delivery. I probably was in heart failure, and it was clear to the people that were treating me at the time that it was heart failure. But I was in pretty bad shape back then. And it was really scary. And I think we need to understand more about those fluid shifts, especially I was non-obstructed. We really need to understand that more, which is why, in part, we put together this writing committee. Yes, it's safe to have a pregnancy, but we don't want these moms to deteriorate their own health to carry that pregnancy. We need to come up with ways to get them there.
I would say, I'm a father of 4, and I just tell the moms, we'll watch you real carefully. I see them very close in follow-up, and I see them when they're in the hospital delivering. I think that it would be a great opportunity potentially for you and your platform to get some data on actually from the moms, like how many, particularly in retrospect, feel like they had heart failure afterwards, because this is one of these, the guideline committee writers, they did a great job without a ton of data, so a lot of it's anecdotal, but having a little, having a reference for some of these things, like how patients do at the time of pregnancy with actual data, that your organization potentially would be probably the best, place to gather, would be really helpful, because I don't think I don't think the risk is prohibitive. I just think we should do a better job of watching and expecting, and so I think that's an opportunity for us to learn something.
I agree. We have a long question here. I'm going to leave it up for just a second. I wish I knew if apical non-obstructive, will the thickening stop or grow at age? Will apex reach the septum? And what are the chances of fibrillation? No scar tissue in my MRI. Thickening is around 15 millimeters. So I'm going to ask both of you to chime in on this, because there's a bit of a misconception in the community. And that is apical HCM is somehow a different disease state than obstructive HCM or septal hypertrophy HCM or lateral wall hypertrophy. Let's talk apical versus other areas of hypertrophy. I'm going to start with Aslan on this one.
Well, there's not a, as there you can have one gene and then have a different family manifestation of way that looks. So it's totally possible to look more apical in one family member and look like something else somewhere else. So you're right. It's not. So it's related to the other conditions. If you look, the genetics, Mayo published this many years ago, but the yield of genetics is lower, but it's still, there's still 15% or so that are gene positive. So it is the same, although different. Certainly, the guidelines treat it the same in terms of the recommendations. So the it's hard to predict on any one person what's going to happen with the septum and everything, but if it's apical, it tends to spare the basal, or the section of that septum that's right under the aortic valve, and affects the apex or the tip of the heart. And the scarring, Mark can talk a little bit about this scarring and the risk of AFib. But we do see hyper enhancement associated with that. Just a lot of the features that we would have with HCM that involves, the mid septum or the basal septum, we would see with apical form as well. And the guidelines don't necessarily treat it any different. In fact, there are some certain stipulations that Mark will probably talk about that alter our decision making.
Mark,
yes. Apical HCM is something that was actually more described in the Japanese population. They have a much higher percentage of apical. And in fact, it has a name called Yamaguchi's. And I'll second what Aslan said. It probably isn't all that different. It just, we know that the abnormal gene is in every cell in their heart. And why do some patients get septal hypertrophy? Why do some get lateral? Why do some get apical? We don't know enough about that. But we do know that people with apical HCM don't typically get obstruction. So they don't typically get the obstruction that causes that kind of heart failure symptoms. And because they don't get obstruction, they're probably a little less likely to develop AFib than a patient that has obstructive HCM. In terms of the risk for sudden death, this is very important, and it's a common confusion. People with apical aneurysms have a higher risk of VT and VF. People with apical hypertrophy have no higher risk than other people. And that you have to be very clear about that. There's a huge difference between an apical aneurysm, which is a thin-walled balloon structure, versus apical hypertrophy. The apical hypertrophy people are not at higher risk of sudden death.
We have one or two more questions, but this one just made me a little nervous. So Jimmy writes, I recently wore a 24-hour Holter monitor and had roughly 300 abnormalities.
So this is a question. I don't know if we've lost Lisa here, but I at least can see the question, and so I'll answer this one. This is a question about a 24-hour Holter monitor and had 300 abnormalities. I suspect that you're talking about premature ventricular contractions, because that's what people get. 300 is really not that much. If you put a 24-hour Holter on anybody, nearly 100% of people are going to have PVCs, or premature ventricular contractions. So I would say 300, it does not seem that much to me, and I wouldn't be concerned about that at all. I'll let Aslan answer the question about the nitroglycerin, since that's in his ballpark.
Well, yeah, I'm not sure if if Jimmy has hypertrophic cardiomyopathy, in which case it's a little bit more worrisome in terms of the medical management. But if it's, that sort of depends. But I'll echo what Mark says. 300 abnormalities. I guess it's unclear. Is that runs of AFib or PACs or ventricular tachycardia? It's hard to know exactly. PVCs in of themselves, probably not. Nitroglycerin, if you have hypertrophic cardiomyopathy, would not be the right thing to do. That would, and we should probably, should probably get somebody to talk to somebody about that. It's unusual to treat chest pains without any firm diagnosis with nitroglycerin. So it's probably worth establishing. Okay, yeah. I would probably avoid nitro with hypertrophic cardiomyopathy.
I'll jump in. I think you might be having some.
When nitro becomes a problem is especially if you have obstruction, it lowers the blood pressure, and people with obstruction can have real problems when their blood pressure is lowered. So it's the same reason people with hypertrophic cardiomyopathy have real problems with dehydration. And you have to be very careful not to get dehydrated because the obstruction can worsen and symptoms can worsen.
So I don't know if we have a technical issue. Mark, can you hear me now? No, he can't hear me. So,
I see that you're non-obstructive, which is better, because it's the obstructive people that have a lot of problem with the nitrates.
Yeah. Well, it still wouldn't necessarily be. There's no exact reason why nitroglycerin would be helpful in the non-obstructive patient with hypertrophic cardiomyopathy. So.
Okay, I think we have a little bit of an audio problem at this point. Can the doctors hear me at this point?
I can.
You can. Okay, Mark can't for some reason. I don't know what happened. So I'll tell you to throw him a note, but you're a door or two away. I'm going to wrap up here. I'm going to thank you both for your time and attention and answering these questions.
Yeah, I don't know. I can't hear.
I know.
Or see Lisa.
Okay, Aslan, tell him I can hear him.
Yeah, sorry about that. I should act as the intermediary. She can hear you, and she thanks you for your time, and she's going to wrap up here.
Okay. I do want to go back to Jimmy for a second and explain that hypertrophic cardiomyopathy and nitroglycerin, it's actually a contraindication if you were to look up the in the medical guidelines for prescription writing. So I would highly encourage you to reach out to an HCM Center of Excellence and make sure that your care is where it needs to be. And if you have any questions, you're always welcome to call the HCMA and we can help you find the appropriate resources. So thank you very much to both of you. Have a wonderful day. And the HCMA is really looking forward to our collaboration with UT Southwest. Thank you, guys. Bye-bye.
Thank you so much. And she says thank you, Mark.
Thank you.
Bye-bye.
Bye.